I'm Dr. James Amos, consulting psychiatrist at the University of Iowa Hospitals and Clinics in Iowa City, Iowa. And once again, this is a dirty dozen, another geezer video, of which I have several presentations on my blog site at the Practical Psychosomaticist at jajsamos.wordpress.com. This is a dirty dozen on somatoform disorders. And the somatoform disorders are complicated. There are several of them, and they cause a lot of frustration for both patients and physicians. The book that Dr. Robert G. Robinson and I co-edited, Psychosomatic Medicine, An Introduction to Consultation Liaison Psychiatry, has a very nice chapter on somatoform disorders written by Dr. Kathy Kaufman. And I'm just going to read the background about somatoform disorders in this chapter. Medically unexplained symptoms have been estimated at about 10%. Estimates are that 27% of patients present to outpatient clinics with unexplained conditions. These conditions are seen frequently by various medical specialties, and these conditions include chronic fatigue syndrome, fibromyalgia, multiple chemical sensitivity, non-cardiac chest pain, and non-epileptiform seizures. Now, I'm not saying that any of these conditions are not real. They are certainly real to patients, and they cause a lot of suffering. But they are often without sufficient medical explanation, and these patients can put themselves at risk for invasive procedures, lots of toxic medications and specialist referrals that can make life difficult for everyone. The slides are here in front of me, and I'm going to refer to them, and that will keep me on track. There's a whole presentation on my blog site, including annotations to the slides that I'd encourage you to look at. Somatoform disorders are often referred to as medically unexplained physical symptoms, and hospital costs associated with these disorders is about 6 times higher than controls. Ambulatory costs about 14 times higher, and the estimated annual cost could be as high as $256 billion. The consequences of medically unexplained physical symptoms are grave. They often impair the physician-patient relationship, and there tends to be a dose-response relationship between the number of symptoms and the level of physician frustration. So 0 to 1 symptoms don't cause a great deal of frustration, but as you go up the ladder to maybe 6 or 9 symptoms, about 23% of physicians find that this is very frustrating. Patient dissatisfaction tends to be high, and there's a fair amount of comorbidity with depression and anxiety, poor quality of life, and high healthcare system utilization. Medically unexplained physical symptoms are seen by a variety of medical specialties. Somatization disorder is sort of the best example. It's a chronic, complex somatoform problem with multiple complaints, often beginning before the age of 30, and prevalent at about a rate of 0.2 to 2% in this country. It has been proposed for the DSM-5 to rename it as complex somatic symptom disorder, and this is unlikely to change the way that we manage it in the near future. The next slide, slide 5, is a list of the diagnostic criteria for somatization disorder, which you can look at. The symptom count is 4 pain symptoms, 2 gastrointestinal symptoms, 1 sexual symptom, and 1 pseudo-neurological symptom. And these are not intentionally produced or feigned as they would be in factitious disorder or malingering, which I discuss in another dirty dozen presentation. Body dysmorphic disorder and conversion disorder are on slide 6, and these are summaries only. Body dysmorphic disorder may be reclassified in DSM-5 with the obsessive compulsive spectrum, especially since it seems to have more in common with obsessive compulsive disorder than with a strict somatoform disorder. Many of these patients seek help from cosmetic surgeons. It's comorbid with depression, anxiety, and OCD. There's profound psychosocial dysfunction, and these people believe that they have a physical defect that no one else can see, and it makes them miserable. Cognitive behavioral therapy and selective serotonin reuptake inhibitor antidepressants are often helpful. And conversion disorder, another common presentation of somatoform disorders, is probably going to be recategorized or at least renamed as functional neurological disorder. Again, this is unlikely to change the management strategy, which is to try to avoid confrontation that the patient does not have a neurological explanation for hemisensory loss or non-epileptiform seizures, and to suggest that symptoms will resolve with supportive treatment or physical therapy. Pseudoseizures tend to respond less well than motor disorders to treatment. There are interesting functional MRI brain studies that show an interesting limbic suppression of activity in the motor and somatosensory cortices. You should look at the Feinstein reference to learn more about that. Hypochondriasis and pain disorder. So hypochondriasis is a preoccupation with bodily symptoms or function and persistent belief that the symptoms are related to a serious disease with no evidence to support it. It's similar, so much so in phenomenology, to anxiety disorders that there's been a proposal to rename it illness anxiety disorder in the DSM-5. Pain disorder is, just like it sounds, a preoccupation with bodily pain complaints, low back pain, abdominal pain. Sometimes these types of somatoform disorders are very common in surgical services as well. There are special cases of somatoform disorders, and one of them is actually an accusation, not a diagnosis. The special cases of somatic presentations of primary psychiatric disorders would include major depressive disorder and anxiety disorders such as panic disorder and generalized anxiety disorders. These often have a very prominent physical component. Factitious disorder and malingering, I once again have covered in another Dirty Dozen presentation. Factitious disorder is mainly about lying to doctors and deliberately producing medical syndromes and psychological syndromes as well. Malingering is not a psychiatric diagnosis, it's an accusation. People are lying about having usually physical symptoms, but also psychological symptoms as well, in order to get something or to get out of something, to avoid jail or to win a lawsuit or to get disability, for example. The next slide, slide 9, is about the goals of collaborative care, and it's really essential for psychiatrists and primary care physicians and other medical specialists to work together to ensure that the patient does not suffer at the hands of medicine, and that those who have other treatable comorbid psychiatric disorders such as depression and anxiety get adequate treatment with evidence-based forms of psychotherapy and antidepressants. The approach really should start with validation. Many times these patients have been to many doctors who have somehow managed to give them the impression that they think it's all in their head. And this is incredibly insulting, and we should endeavor to treat these patients with respect, support, and that's validation. You don't necessarily have to tell them that you believe that they have a specific disease or that their somatic complaints have a find it and fix it physical cause. Management for the person who may somatize chronically once again involves a conservative approach, trying to avoid specialist referrals, toxic and or addictive medications, and surgical interventions unless there's objective evidence to support doing those. The slide 11 is selected references, as usual, and the last slide is sort of a tribute slide to a mentor of mine, Dr. Russell Noyes, who developed the Health Attitude Survey, validated in a study published in Psychosomatics in 1999, and it was administered to over 1,000 patients attending a general medicine clinic. It's originally a 27-item scale that was rapidly administered and acceptable to patients, and identified patients who tended to have somatoform disorders as compared to controls. And that's the end of this presentation. If you have any questions or comments, please don't hesitate to drop them off at my blog site, the Practical Psychosomaticist. Thanks very much and have a good day.